Hello.
Yeah. Okay.
Let's get back.
So while going, we did end the stream once it finishes. Correct.
Yeah. Okay. Good morning. Final session here. It's another exciting one. Our colleagues from the Transformational Healthcare Group, led by Ashley Gambier, a long-term friend, and in fact, proud to say one of our alumni from Rady. So Ashley is going to orchestrate this and bring us this fantastic team that's going to tell us what they are doing here. Okay, over to Ashley.
Thank you, Nish, and thank you so much for bringing all of us together today. I think it's a really wonderful city to live in because we have such a community of innovation in San Diego. Bringing together all these different stakeholders into a room for 2 days, spend time together, connect, get inspired, and talk about what it takes to really transform healthcare and innovate in medicine. It's definitely not a small challenge. And we've talked this morning already about a lot of those challenges and opportunities. Has anyone seen the new Wonka movie? Yeah. I really like Willy Wonka because, and for those of you that haven't seen the movies or read the books, I love that he just relentlessly tries to make dreams come true. And he's completely unrestrained by reality. And there was research 65 years ago that shows that every year we're alive, we get less creative. And I like thinking about Willy Wonka because he kind of exemplifies forgetting about that and saying, I'm going to do it anyway. I'm going to live in a playful space. I'm going to live in creativity. And okay, thank you. And kind of inspire us to challenge ourselves there and not get stuck. I'm really thankful because I get to work with an incredible team here, and we're going to share some case studies and some things that we're doing to try to translate really cool innovation into the practice at UC San Diego Health and our medical centers and our ambulatory practices. And we're going to spend a little bit of time challenging some of the assumptions about healthcare innovation and transformation. And I'd like to start with some truths that I hold. I'm Ashley Gambier, and I'm the Executive Director for Healthcare Transformation at UC San Diego. And what we do is really focus on integrating operational and culture changes to support an environment where we're constantly evolving and offering our patients more. So the first truth that I'd like to offer is that strategy requires innovation. Strategy is about creating competitive advantage, meeting your patients' or customers' needs, growing. You can't do any of these things without doing something different. And you can't just do more with less or implement cookie cutter solutions in order to innovate. You have to kind of push yourself to innovate, and I define that as doing things better or doing better things. And both of those are all about having value. But you can't have innovation without transformation. At least it won't stick. In order to do things differently, you have to do things differently. And that's all about change and successfully navigating change. And in order to do that, you have to have really strong leadership. And I'm not just talking about top-down leadership. It requires leadership at all levels. Entrepreneurs, yes, they have to sell a vision and fundraise, but they also have to have a lot of support from many people in a lot of different arenas to help get that idea into market. And for companies, this is also not something that you can just have a top-down, let's just make this happen, because your culture is going to very much impact your ability to integrate that. Sometimes we fall into that situation of purchasing a really shiny new gadget and it doesn't get embraced, or outsourcing something like this to a consultant, and they don't understand who we are. And so it's very important to think about what we need to do from a leadership standpoint at many levels in an organization to make sure that these changes are adopted. And sometimes, in fact, probably most of the time, some of the most impactful transformations are not very innovative. They are smaller activities like standardizing, streamlining, and simplifying efforts that you're already doing. These continuous improvement efforts make things better, faster, cheaper, and more consistent. And sometimes that's more transformative than big, fun, and splashy things. So I'd like to include those in the definition of innovation today. Some of you are entrepreneurs and you have ideas for great products and startups that are going to transform healthcare and solve some of the biggest problems we have out there. And I love that. Thank you for doing that. That is not an easy situation to be in. My husband's an entrepreneur in med devices, and I know that is a very challenging world to be in, as exciting as it is. And some of you here are more entrepreneurial. You're part of an established institution, or you aspire to be part of a company that is really innovating from within. We don't talk a lot about entrepreneurship, but I think it's worth mentioning today that that is kind of the space that I feel myself and our team are in, more in the entrepreneurial space. How do we actually make these things happen within an organization? 45 years ago, that term was coined, and it's hardly ever used. But Steve Jobs actually is one of the most famous entrepreneurs, but he regarded himself an entrepreneur because he only had to start Apple once. He had to reinvent it many, many times. And this is something that is really worth pointing out because entrepreneurs, they have a lot more freedom, but a lot, fewer resources, right? Whereas entrepreneurs have access to a lot more resources, but sometimes they really have a culture challenge that they need to work through because as companies have success, they tend to get a little stuck and they need to evolve, and that's a lot to navigate for an entrepreneur. Some of you may have seen this before, Rolf Smith's 7 Levels of Change. And I think it's a really helpful framework when you think about how big is this innovation. We think about, my son, when he was 4 years old, got a cavity. And as a parent, I felt terrible. I felt like I had failed my child, and now he's going to have his mouth drilled, and he's 4 years old. What changes can we make so this never happens to my baby again, right? Level 1 change, are we brushing our teeth twice a day, right? Level 2 change, are we doing it for a full 2 minutes? Level 3 change, maybe we get one of those fancy toothbrushes with sound wave technology, right? We keep leveling up, and eventually we are actually solving a problem in oral health. Maybe we're eliminating cavities in baby teeth completely, and people thought that was impossible. But I want to mention this because when you think about some of the most disruptive changes, they come at all levels. The iPhone was actually a level 4 change. Let's get rid of the keyboard, right? It wasn't an impossible change. And so I mentioned this to inspire to think about innovation that's needed kind of at different levels in here because it can all be very, very impactful. Sometimes it's the simplest things that make the biggest impact. For entrepreneurs, I don't think it's quite as linear because you already have existing services, products, you have existing customers. So as you, this is the ambition matrix that was published in HBR about 10 years ago. This looks at these innovations kind of on a matrix, a spectrum where if you are innovating and it's related to your existing products and your existing customer base, this is kind of what I consider to be continuous improvement or incremental innovation. But if you're starting to push into new markets, new products, new services, this is where it gets transformational. And I think it's really important to have a portfolio with both because those big, big changes need those iterative improvements to stay relevant, to actually work, because you can't design for perfect the first time around. So when you have big innovation and continuous improvement happening together, it really creates a sweet spot that allows for the highest performance standards to be met. It allows innovation cycles to happen more quickly and actively building an environment that allows for that pace of change requires a lot of leadership and culture management. At UC San Diego Health, I'm really fortunate to be in a role where I get to help build a culture where transformation is possible. We have a vision statement to create a healthier world, one life at a time, through new medicine, new science, new medicine, and new cures. All of those are kind of way up there on that ambition matrix, right? But this requires strategy and innovation, and we have a vision for transformation that requires tapping into the collective intelligence of the incredible people who work here. We have some of the smartest minds at UC San Diego Health, and actually allowing them to be part of innovation on a regular basis is tremendously impactful for us as an institution, but also for them to be part of the ecosystem and an environment where they get to be innovative. And part of this is that we must be a learning organization. We teach, but we constantly have to challenge ourselves to learn new things, approach things differently, meet needs in different ways as everything around us in the world is evolving. And part of our Willy Wonka mindset, right, is to challenge some assumptions. So I want to start with some myth busting. The first one is innovation is always original. This is a huge myth. It can be very original, absolutely. But our brains are actually incapable of coming up with something that we had no remote exposure to before. Some of the biggest innovations comes from applying something that's been done in another industry in new ways. And in 2016, UC San Diego Health actually lost a bid to be a healthcare provider for one of the largest employers in San Diego. And we were really kind of shocked and unhappy, and of course we wanted to care for San Diego, that's our mission. It forced us to have a moment of identity reflection. They didn't choose us because we didn't have a physical presence where their employees lived. We weren't convenient. We were making people come in to help us in Hawaii for almost all of their care. And we had to decide, who do we want to be? And we decided we want to be where people live and work. We want to be present in people's lives when they're healthy, not just when they're very sick. And part of this would require growing our outpatient practice. And so we had a big challenge. How do we grow, do this in a financially sustainable way, which is not easy in academic medicine, and do it in a way that provides a really good experience for our patients and for our caregivers and our care teams. And you wouldn't think that healthcare can learn from a theme park. When you think about designing spaces, the first place wouldn't be Disneyland to look to, but that's actually what we did. And Disneyland actually stole some of their ideas that we leveraged from theater. And what they took was this concept of onstage and offstage space. So in theater, your audience can only see what's on the stage. And behind the perimeter of that, behind the curtains, all sorts of that stuff's going, costume changes, people rehearsing, people drinking coffee, whatever's going on back there, the audience has no idea. Disneyland really embraced this. And when you go to Disneyland, anywhere that a visitor can be is considered onstage space. And their team members, they actually call them cast members, to help them really think about that. They're a cast member, they're on a stage, anytime you're somewhere that a visitor can see you. But there's all sorts of secret doors all over Disneyland, and they can go into offstage space. And that's where they can relax, they can talk, they can do all the things that they need to do and not worry about creating an amazing experience for their guests. And when we think about healthcare spaces, there's actually a lot of those similar needs. So we pulled together a team of doctors, nurses, front desk, back office, janitors, and patients. And we put ourselves in a room and we had a design session where we said, how could we leverage the concepts of onstage and offstage space to design a better outpatient clinical design? And we did it. This is actually a picture one of the teams drew on butcher paper during that session. And you can see it has come to life. This picture on the left is a door that would attach to the corridor that goes to the waiting room. And those corridors were designed to be the fewest number of steps for the patient from where they wait and where they enter the exam rooms. And then you can see a second door is added to the other side of the exam room. It's open right now, but typically during patient visit it will not be. And if you look through there, you're seeing the offstage space. There's workstations where doctors and nurses can co-locate. They can efficiently hop between patient rooms without having to go all the way through the corridors to enter. If they need something in the middle of a visit, they can just open the door and ask someone to bring it to them. This on-stage, off-stage concept has ended up being tremendously impactful to the patient experience, to our care team experience, to our operational efficiency, and it's become a blueprint for all the ambulatory spaces that we look at ever since. So, myth busted, you can totally steal things from other industries or other places, do them in unique ways, and that is very innovative. Our second myth, if you build it, they will come. This one we see a lot. Really great product, really great technology, really great idea, but there's not readiness for it. This is a photo from 2019 of some of our telehealth equipment collecting dust in a closet. And there's been technology to support effective telehealth happening for 20 years. We've got Skype, we've got all sorts of things that we could use to effectively deliver telemedicine. And it wasn't until COVID that there was finally readiness to truly embrace this. And it wasn't just people's mindsets, like patients or doctors willing to do it. It was everything else that actually cleared a path for it to happen, right? We needed to change policies related to reimbursement. We needed to change workflows. We needed to allow people to work in different locations. We needed to figure out where these visits were going to happen. Oh yeah, and the technology. And so I think the myth here is, if you're thinking about a disruptive technology or something that people aren't using yet, you also need to, as the innovator, create the readiness and the demand for it. Because people are very comfortable with status quo. And there's a lot of barriers to change that have nothing to do with the technology. So, second myth busted. And the third one is that training is enough. And I'm going to tell a story to kind of explain this one. There's a lot of evidence base that supports carbohydrate loading before surgery. Again, stolen from another space, just like a professional athlete. So they're going to expend a lot of calories and not eat for a while. You carb load because your body needs that energy to help you. And similar with the surgery, the anesthesia, you don't eat for a while. You fast beforehand, then you're recovering and you're not eating. And you need a lot of energy to start healing. So there's a lot of evidence to support having some ensures or carbohydrate drinks before your surgery. It's going to improve your recovery. And there's other things, like chewing gum after surgery can help get your motility going faster, and that helps you recover faster. Having a CHG bath reduces the chance of infections. So there's a lot of things that a patient can do to improve their recovery. And this is known. There's tons of journal publications on this. It's been presented at conferences. This information's on the internet. I pulled this image. I just did a Google search. About 100 different of these flyers popped up with information about this. It's known. But it wasn't happening every single time for every single patient. And so training isn't enough. We have very busy people, and they place an order for a surgery. Then they also have to remember to place an order for the gum and the CHG bath and the carbohydrate drinks. And it's a lot to remember, and the result of just training people is a lot of variation in implementation. So where does the innovation come in? We decided to invest in creating the Enhanced Recovery After Surgery program, which involved training, yes, but it also had a very nice partnership with our information services team, where the Epic, our medical record, when you place the order for that surgery, you bundle it. You bundle that order with, as an order set with a bunch of other things, like ordering the carbohydrate drinks, ordering the dump motility, ordering the CHGF, and it's easy. It becomes the standard of care because it's baked in through our workflows, through our technology, and it takes training to the point of standardization, so that is the standard of care every time for every patient. And the only time you wouldn't do it is if that patient had diabetes or some reason they couldn't have that carbohydrate drink, right? So when you can take beyond training and help design ways to make that training actually become the new way of doing things, I think that's where this partnership between people, process, and platforms and technologies that you have to support the transformations that you're trying to make. You really look at them together in concert. And it makes a huge difference to have kind of that broader lens when you think about creating an environment where this can thrive. So we're going to talk a little bit more about that. My colleague Sarah is actually going to do a deep dive case study into our Sprint program, which is a perfect example of where people, process, and platform intersect. One of the biggest epidemics in healthcare right now is physician burnout. It's hugely impactful and it's rampant. And there's some thought leadership from Tate Shanafelt that demonstrated that 20% of that burnout is attributed to the electronic medical record system, right? It has changed healthcare completely and it drives us. And so this idea was to create the Sprint program to address burnout by making the EMR less frustrating and less painful, and doing this in a very unique way. So I want to talk to invite Sarah up here to talk to you about that. And then Rick is going to talk to you about how UCSD supports that culture of innovation, and doing that with a backbone team we call transformational healthcare. And then Dr. Alcara is my physician dyad partner, and he's going to talk about just kind of, we talked about this a little in the last talk. In healthcare, it's not like other businesses, because sometimes what we want to do is prevent the types of care that provides the most revenue, right? We want to do things that keep people from needing our services. And so it's a very unique situation to be in, and there's no end to transformation, because we have to, just like Dr. Longer said, we want every single patient to have the safest experience, and we want it to feel really good to them to be getting their care here, and we can't ever stop. So with that, thank you, Sarah.
Thank you, Ashley. A lot of you, if you do know me, you know I am already a very loud person, and so giving me a microphone is always an honor for some of us, and maybe a challenge for others, so please let me know if it becomes a bit too much. I am Sarah. I lead our Sprint program. I came to UCSD in April of 2020. If you guys can remember what was happening in April of 2020, we were all sent home. That is how I started my career at UCSD for a program that was designed to have a 2-week in-person intervals at clinics at UCSD to make providers' lives better. You can imagine the drastic, quick shift change that we all had to come into. We quickly came with innovation. This is where we shifted. We always made true to stick to our we hear you, we see you, and we support you. One of the things that drives me that I'm passionate about is I am passionate about people. People in the hospital, people at home, people on the train that we pass by. And I think by giving people the space to be vulnerable and accepting, we can be our best selves. When we go through this, we want to make sure that we can have the opportunity to then have the innovation, to have someone to listen to you, to break down that barrier. That's what our Sprint program allows for our clinicians to do. So we work with other universities in the UC system. In addition to that, we work with Mayo, we work with NYU, we work with Texas hospitals. We also have the opportunity that we get to meet together about once a quarter to discuss different areas of innovation, of opportunity that maybe we haven't thought of before. So it's definitely a unique team who created a culture inside of UCSD and along outside of UCSD. But at the end of it, all of our goal is to make sure that we can work with our EMR, Epic, not us battling against the system. It's a constant struggle. We always want to put data in. We want to be efficient as possible. So that's our goal with our program. Again, when we first started, our take was supposed to be in the clinic for 2 weeks at a time with trainers, evaluating, watching the workflows. We have 2 analysts from that point that would have done real-time changes and updates to make it a system efficient. Again, for all clinicians, front desk users are billing users. That went out of the window in April because of that. What we were able to do, though, is shift this to a virtual setting, the silver lining of having conference calls. What we also realized is that we were able to meet providers outside of the clinic. What this also gave us the opportunity for was allow clinicians to be vulnerable, and a different vulnerability from what they had when we were actually going into the clinic itself. As clinicians and providers, we know when we're in the office, we have our utmost professionalism that we want to experience for everyone. Our patients will come first. Our staff members that we support will come first. So when you have trainers trying to follow you around and say, how can we help you? That is not the idea of what our physicians are going through at the time, because they're not thinking of how can I help myself while I am backed up by 30 minutes in clinic, an hour. I have an emergency room patient that just came in that I've known for 15 years that I really want to see because they have been with me for this long and I've created this connection. So here we are 3 years later, and we're keeping with the virtual setting. We've had more providers be able to come to us in this area that we can actually listen to what it is that they need to treat our patients. And our patients aren't just numbers, they're our community, they're our neighbors. They watch our children after hours when we're working too late, they're our grandparents. So we want to make sure that while we're looking at causes of burnout, not only are we addressing efficiency and workload, but it's our culture and values that we can really get across when we have that vulnerability and that time to allow that space. With our sprint program and outcomes that we've seen go into the virtual setting, we've seen a 55% decrease in Epic in-basket turnaround time. So that means if it's taken you 5 minutes to reply to a message, now we're doing it in 2.5 minutes. And if all of us know that we have our caseloads have leveled up so much further, we just talked about canceling and addressing surgeries, patients coming in, we want to help them faster and more efficiently. We don't just want to do it quickly, we want to provide the care that we know that our patients need and deserve. Along with that, we can also do education and real-time edits. So we have the amazing trainers on our team that have over 10 years of experience each. But while they're working with our clinicians, they can also go in the system. And if there's small edits that can be made, they can do that for them then and at that time on an individual basis. We also have the opportunity that we get to meet daily as a team member, and we look and see if something should be for an individual provider, or is this something that we should take and level up to the entire health system. We are very fortunate that UCSD gives us the opportunity to actually make those changes. They give us the opportunity to address them and go further, and we can have impactful meaning, again, for all of our staff members, our patients that come through our doors. We also are meeting targets achieved to close charting after hours, which is also an interesting topic. I know a lot of us like to do our work after hours because we want to dedicate our patient-facing time when we're in front of the patient. That doesn't mean it needs to take as long as what it does now. So our goal is to decrease that time regardless of where you choose to do it. That is for your workflow to choose, but we will help you make that decision and make it effective as possible for you. Myth 4 that Ashley, we were discussing earlier, innovation must be about big change. Sometimes it's those small changes that can have the large impact. It's a ripple effect. We met with multiple providers that one of the areas they brought in is as they were going into their in-basket, which if you work in the health system, you know the beast of the in-basket where our patient information comes to, often with tasks or information of what needs to be done for those patients for different areas. we realized there was the blue circle of death continuously happening while going into different areas such as test results, image results, patient messages from my chart. This is not helpful as we are trying to address our patient concerns, but yet we can't actually read them and get into them. So we were able to take that back to our team to see where was it that was causing the digital errors to occur. Well, as we were looking for it, we realized we couldn't pinpoint the actual problem because we had such a large volume of messages in the system that dated back to 2013. So we said, how do we find where this is coming from? Let's remove the messages that are older than 13 months. I can tell you part of burnout and a part of areas of concern is letting go of some control that we have and the fear of losing data. Well, making sure with our team of experts, knowing that this information that was in the in baskets was going to stay in the patient's chart where it belongs, does not need to live in the individual providers' in baskets themselves. We could remove them, also confirming with our compliance and legal departments at the same time and having a group in there that we're still making the right decision to get these removed. As we started the 13-month and older messages removed, it was 2.8 million messages that needed to be removed out of the in-basket as a whole across the system. We were all very, very nervous when we hit submit on that to pull it out because we knew it could have gone multiple ways, but we were very fortunate it was a success. And with that, not only did we see these messages removed, but we also saw the response time when going into the in-basket itself without delays. So we know that we can say 1 click is a second, which gives us 66.4 hours. If you think about it, that'd be a person sitting at their computer, just clicking done for that long. Now we don't want to say this gives back 66.4 hours a month to anyone because we all know that all of our clinicians are working above and beyond the hours in a day that are technically possible. For us, this shows hours taken off of the plate that you may go home and think that you didn't get something accomplished or fear that you missed something in a patient's chart. That's what those 66.4 hours represent. But also with that, our response time and being able to actually navigate through the system and not have to close out of your system, restart your system, reboot your system, that also is impactful. We've talked about AI learning and supporting and the information that goes in there. This also supports this area. We want to make sure that you can see the data as it comes into you. So when messages are coming in now into your in-basket, it is actionable items that you know is going to deliver for your patient healthcare. We're also removing message types that no longer give you items regarding your patient. We want to make them actionable and informative for you. Not only have we worked on the in-basket improvement, we've also done many other areas to support our providers and our clinicians across the board at UCSD. None of this would be possible if we didn't have the opportunity to create a vulnerable space for our providers to come and talk to us and be with us to actually see where the need is to provide patient care, first and foremost, for our community and for our team members. I was recently asked, what is it that I do actually at UCSD? And it took me a minute because I feel like a large part of my job is telling people no. Another large part of my job is telling people to stop touching things that leads to other areas of things that we then need to possibly clean up or take action on. The best part of my job is I get to sit with a team of people every day that we get to create a vulnerable space for everyone around us to come at their most needed areas of opportunity that then we can deliver the best healthcare to our patients and to our community around us. But this is a culture that UCSD Health, the University of San Diego, offers us, as we were talking earlier, of MyChart and our mental health apps for our patients coming in. We want to make sure that we create this not only for our existing staff and patients, but for people that are coming to us, and that we can create a culture of growth and opportunity for years to come. With that, I'm going to introduce Rick.
Thank you, Sarah. My name is Rick Pippin. I'm the Director for Transformational Healthcare here at UCSD Health. I'd like to open with saying thank you for your time. Thank you for letting me speak with you today. I'm always telling my team, never stand between people and their cars, their calories, or their caffeine. And so I really appreciate, here we are just minutes before lunch break. I appreciate your time and I appreciate your attention. So Ashley really began this talk with differentiating between the intrapreneurial, the entrepreneurial, and discussing the advantages of building an intrapreneurial culture. Sarah gave us some great case studies around how we have brought that intrapreneurial spirit to life at UCSD Health. And I'd like to talk to you about how we build that intrapreneurial spirit into our culture and what our role as transformational healthcare is in bringing that mission to life as well for our teams and for our community. So you might look at some things and see they're very, very familiar. Transformational healthcare, we have two things in common with every other performance improvement team in healthcare. But one thing makes us different. See, the things that we have in common. We use improvement science to close the gap between patients and those who care for them or the products that they want, right? These are things about improving access to care, reducing inequities, and getting people in front of their care teams. These are things like reducing waiting times, anticipating demand, and level loading resources at scale to be able to meet the needs of the community, closing that gap. The second thing is that we use that same improvement science to, when that gap is closed and the patients are with their care team, to make that encounter as safe, as efficacious, and as connective as possible. Sometimes that means getting extraneous things out of the way so the patient and care teams can just focus on what matters, which is their health, right? Improved communication, improved patient experience, less noise, more signal. So those are the two classic performance improvement teams that are performance improvement roles my team functions as. But what makes us transformational healthcare is we try to do a third role. We leave teams with the ability to accomplish the first two jobs themselves. We want to empower teams to innovate locally. We want them to be able to see the needs of the patients they're meeting and the care environments they're caring for them in. And we want them to have the spirit, the skills, and the knowledge to be able to close those gaps themselves and not always be dependent on people like myself and my team. So we do that through a bit of education and training. Yes, that is necessary, but it's not sufficient. True transformation, creating a culture of innovation, requires systematic and systemic commitment to building the structures into the fabric of our day-to-day work life. And when we get to that, that's when we start about transforming systems and transforming cultures. Some of you may be familiar with the Shingo model. It's what we use to guide how we think about innovation and the systems that we build around it. It's got to be part of the organizational vision, right? Learning, innovation, they have to be key behavioral indicators. That vision doesn't just exist in words and mantras. It's got to be brought to life. We need to build systems. By that, I mean aligned processes that drive those behaviors, that pull them out of people in those who work in the systems every day, and the infrastructure. And then the day-to-day leadership of the organization must reinforce those behaviors to ensure they're driving to the necessary systems as well. This underpins how we think about the relationship between systems and key behavior indicators. But there's another model that talks about how we spread it, the functional day-to-day piece. Many of you are familiar with the ecological model or microsystems theory popularized by Dartmouth University. But this is really what my team does. We're very, very small. There's only 6 of us together. And we think about this as a healthcare system as a system of systems. We start with these microsystems and helping teams at that level solve problems that are relevant to them and to their populations. As we give those teams the ability to do that third aim, right, improve themselves, we begin to improve the mesosystem. And then over time, we improve the macrosystem. This is a time-intensive, organizationally attention-intensive process that takes years and years and years. We're 5 years into our journey now, and we're discovering and learning new things every day about how we build that innovation culture here at UCSD. Everything is a trade-off. That classic quote, right? Every system is perfectly designed to achieve the result it gets. No matter how you approach learning and innovation in your culture, there's a serious commitment. If no investment is made, a determination on how the organizational approach learning and innovation was then also made, right? And choosing not to invest means local teams will lack the sufficiency to the self-sufficiency to subsequently improve. And then improvement will be replaced by firefighting. This is just a generic little metric here, but many of our metrics in healthcare look exactly like this, right? We have a key performance indicator that is basically volume dependent. It's a static system in which the systems and processes operate the same way, no matter what the community demand is. As a result, in the absence of any kind of innovation or improvement, the system will perform exactly how the volume tells it needs to. And in this case, poorly, right? Respiratory season hits, all of our end of the year procedures, along with the regular volumes that we have, means our volumes are high and our performance is low. As the warmer months hit, respiratory season abates, our volumes start to dip. Hey, whatever we were doing, whatever we were improving, whatever we installed as an innovation or improvement, it seems to be moving the needle on this patient population. Great. And then we get to the summer months, volumes are low, metrics are great. We all take a victory lap. And then some confusion hits around the fall, and then we get to the winter, and everything's back to the same. Because we were firefighting our way out of this performance, and not really addressing the root causes of the issues. This is throughout. This probably is, many metrics that you'll see throughout the healthcare systems, not just locally here. But it's a great example, I think, of how organizations that have not yet invested in the innovation see the effects of that in their day-to-day operations. But there is, unfortunately, also a cost to investing. And everybody knows that there's a money cost to investing, right? Everybody knows that there's infrastructure. Everybody knows there's platforms. But really what we focus on from our end in transformational healthcare isn't just the platforms and the money, but also the leadership aspect. As Dr. Heifetz once said, attention is the currency of leadership. You need to invest time into reinforcing learning behaviors in your organization if that's what you want your organization to do. When I was first getting into this work, I worked with a case management team. Not here, somewhere different. I worked with a case management team, and we were trying to solve patient flow problems. This team had never really been engaged before, but they were close to the work, hub and spoke model. It was time for us to innovate and improve our way out of this patient flow with excess days problem. And the team put in the work. The people at the front line put in the work. Leadership at the middle tier, that mesosystem tier, gave them the capacity to actually functionally improve. And so they were ready to show off their work, what they had done to the C-suite. C-suite comes down and they give this presentation and say, what do you think? And the CEO looks at them and goes, hey, how often do you print those metrics? There was an initiative going on to reduce the amount of ink that we were using in the organization. That was the first thing the chief executive asked. That was the thing that they paid attention to. How hard do you think it was to get that team bought back in to improve the next time? Fast forward a year later, different team. This one was an emergency department team. Same problem, patient flow. Different solutions, some innovation and improvement going on simultaneously. Created new spaces where we didn't have it before. Used some different ways of thinking about the physical plant. And used temporary structures to design, model, and test it. C-suite comes down and says, oh, this is great. We've increased capacity by 20%. We're seeing more patients. Lower left without being seen. This is phenomenal. They said, if you want to make it permanent, here's what it was going to cost, $10,000. The chief executive looks at the cost, looks over at the chief financial officer and goes, you think we can swing 10 grand? Yeah. Never had to worry about that team's engagement in the innovation process again. Attention is the currency of leadership. The second thing here, that the cost of investing, is you have to build the system that drives the behaviors across the organization. We can talk, we can pay attention, but the systems aren't driving the innovation we want, where our colleagues can see the patient need and have the resources and capability to fulfill that need, will still be just words. For us, we've selected Lean as our learning system of choice across our organization. This slide scares a lot of people because it's complex. These are all the different components of a learning system within the Lean framework. We've been on this journey for about 5 years, and I think we've installed 2 of them. It takes a lot of work. It takes time. Transformation is not simple. And so I use this model to kind of illustrate how we might build learning systems within the Lean framework between the micro, meso, and macro systems, and to illustrate to leaders what their breadth of options are, right? How we can help them build those learning cultures where they need them, and then what that framework is for the long-term growth of the organization. This has turned into, for us, the last 5 years has brought us some stellar tools, results, and ways of building people. I like to talk about the daily huddles and, as a way of making sure that information is exchanged between the different systems. Our idea boards that are there with them in this place where work is being done are we're soliciting ideas and giving them the space to talk about how they might act on those ideas right there in the workplace as well. And then not just in the individual workspaces at the micro and meso level, but also crowdsourcing through our Idea Wave campaigns to solve bigger problems that affect the whole health community and leveraging, as Ashley said, the collective intelligence of our organization. Finally, my team works a lot in these workshops where teams have identified very complex problems that they are facing in their workflows or their day-to-day life treating their patients. And so we go and help them deep dive, characterize the problem, brainstorm solutions, and then get their performance in front of senior leaders so they can pay attention to the great work they're doing, improving the lives of our patients in our community. Finally, Process Palooza. This is my first year with Process Palooza, and I'm really enjoying just being a part of the spirit and the culture of connecting campus to the health side, where we are finding teams engaged in common problem solving, teaching them improvement science, and then collaborating together over the course of an eventful weekend. The last thing I want to say is, above all, to borrow from W. Edwards Deming, substitute leadership. If you think you can get innovation from exhortations, posters, or performance incentives, you can't. Substitute leadership instead. With that, I'd like to introduce a UCSD health leader who's embracing this challenge. He's prompted me and my team in the short time that we've worked together to innovate around making our improvement science products much, much more available to our clinical care teams. Please welcome Dr. Robert L. Carroll.
Really great to be with all of you, and honestly, an honor to be part of this fantastic program. And I recognize a former mentor of mine said, about presenting, start whenever you want, just make sure you end on time, which I will make sure that I do. So I am just going to spend a little bit of time talking about, my view of certain areas around the healthcare system that represent ongoing challenges that likely would benefit from new ways of approaching solutions and targets for new innovation. And I'm coming at this from a few different but very connected perspectives. I serve as Associate Chief Medical Officer for Transformation and Learning. I also serve as a practicing hospital medicine physician and get to see a lot of these issues firsthand. And I'm also one of the clinical informatics faculty, which allows me, as we all talk about the electronic health record being the bane of all existence, is also, part of all the solutions that everybody proposes as well, just because it's so ubiquitous in terms of how it affects the care that we provide. So, looking back at what my great colleagues have already presented, Rick really described how establishing culture and creating leadership is going to be really a crucial aspect of getting this ongoing improvement established in our organization. And so when we do this from within the organization, those two parts are especially really vital in order to make progress here. And so my connection and my partnership with Ashley and with Rick as part of the transformational healthcare team is to get our physicians and our trainees part of that culture, part of the leadership training in particular. And so we have this shared vision that all of our healthcare team members would feel both capable in doing this work and really feel a responsibility to identify ways that we can improve the system, and then also participate in some of the interventions to address those things, or at least connect them to other people who will address those problems intentionally. So, I will say that, like pretty much everybody in this room, I have a lot of optimism and excitement about how AI can tackle these variety of challenges that we have in our healthcare system. But you will note that the presentations so far have really only mentioned AI very briefly. And that's because, AI is obviously a broad set of important tools, but as a set of tools, it needs to be matched to the right job. And so one of the things, meaning that we need to really understand the problem that we're solving to the level of detail to recognize, is this a problem where AI or one of the AI tools is best suited to do it? Or is this a problem where maybe a different approach would be more advantageous? And so that's one of the great and important ways that transformational healthcare approaches can help us, is to help characterize what that problem actually is, and then also help to understand exactly how we might integrate some of these innovations into pretty complex care systems. And so Sarah talked to us a lot about how we can apply these types of approaches to help with our clinician burden and some of the challenges that they're seeing. And I'm going to talk a little bit more about how these challenges affect our patients. And one of the benefits of going later in the agenda is that we can have callbacks. And I just want to, this is a great callback to Dr. Longhurst's reference to patient safety. And that's a big focus of a lot of the work that I do. So I don't have to go through the details of the Bates article that was published last year. But just to recap, it's been 20 years since the patient safety movement was underway. And they found that adverse events occur in 1 in 4 hospitalizations, and that 1 in 4 of these adverse events are preventable. So, these are like Chris mentioned, these are things like adverse drug events, procedural complications, hospital-acquired infections. So, if you think about that, here we are. If you're a hospital system roughly the size of UC San Diego, and you have maybe 39,000 admissions per year, something like that, that translates into 2,400 preventable adverse events per year. And then you multiply that by the number of hospitals like that around the country, and obviously the scope of this problem gets big quickly. And so there's really an imperative to address patient safety in one particular area where some of this technology and some of this innovation is directly affecting us, our family members, and so forth. So if we take a step back, and I look around at, where are there ongoing opportunities that could benefit from all the innovative thinking from people in this room? Nicole mentioned that the CHI uses a quintuple aim, and that's what I use too. From the IHI's quintuple aim, shown here, where health equity is one of the aims that kind of is pervasive across all the others. And I use this framework to think about where are the real challenges that we're still not, we haven't solved yet. And so I'm not going to read all these out to you. You can scan them briefly. I think that we saw that we have a handful of clinicians in the room. I'm sure that these are not surprising to you or others who have encountered the healthcare system. And by no means is this exhaustive. But I will say, I'll just point out that we talked about patient safety being a huge problem in the hospital, and that's one component of one of these. And so these challenges are broad, they're big. And I'll just say that the transformational healthcare approach, one of the things that I find especially useful is it allows us a proven method to go from one of these broad challenges to a more focused problem, and then dig into a very well-defined need. And so then we can use that need to say, okay, well, sometimes, as was mentioned, sometimes the need is just for a small change that actually has a huge impact. Sometimes the need is for a big change that's very disruptive, and that's where we really need to figure out where do we apply the right tool for that particular challenge. And so I'll just sort of to wrap up here say that we talked a lot about the value that the transformational healthcare team provides, and that all of us who want to do improvement in the system, we want to make big leaps. There are lots of challenges. We need to make big leaps because there's a lot of ground to make up. However, as Ashley mentioned, as Chris alluded to in his first talk, that innovation needs to be coupled with the implementation, needs to be coupled with knowledge of the workflows and process redesign. And so working on that, those approaches, developing the culture internally, developing the leadership up and down, that's how we put those intermediate rungs in to make sure that we continue to make progress on all these efforts and continue to push our healthcare system forward. So thank you. I know that all of us would be happy to entertain any questions or comments in the minutes we have prior to lunch here. Thanks.
Okay, I know we are just about a few minutes away from lunch. Are there any questions? I think this is a great session. We might call it the Mythbusters, right? Like, just to show how innovation is still a very practical, day-to-day thing. Are there any questions or comments? We have a mic in the back to go around. Do you have any questions for the speakers? People are hungry. Yeah, there's a couple here.
I was stunned that there 1 in 4. That there is 1 in 4 mistakes.
1 in 4 hospitalizations have an adverse event, right?
That's stunning.
It's stunning. And it's stunning, and I think the particularly stunning part of that, as Dr. Longhurst mentioned, this is similar 20 years ago. And we put a lot of effort into patient safety over the last 20 years. And it's 1 in 4 now. And so what that means is when we think about, okay, we don't want to do the same thing and expect that we're going to see a big change 20 years from now. So it means that this is still a ripe opportunity for doing something new. And that's where I think that, given the scope of the problem, that's where I think we really need to focus our attention on. What do we do new that's going to make that not 1 in 4 in 2020, 2044?
So that picture you had of the picture you had of the bulletin board and this and that, you didn't have a war room.
You mean the war room to address patient safety in particular?
Well.
Right. Well, I think that, part of the effort, and I can let the CHI folks maybe chime in more, but part of the effort, mission control is intended, to do a lot of things. I think patient flow is clearly one big opportunity for bringing people together along with all the data and the models. Patient safety and having a center for patient safety where we bring to bear all the data and the analytics and the predictive modeling would be a huge step forward as well, and to address the scope of the problem that you've highlighted.
So one comment, two comments actually. One is 3 weeks into my term as chief of staff of a sister institution in San Diego, there was a wrong site surgery. And we had to go into crisis mode. I brought in John Webster, who was an old friend, who was the chief at the Medical Center, who kind of wrote the book on patient safety for the American Academy of Orthopedic Surgery. We went into a crisis mode and implemented a whole bunch of changes over the weekend. Fortunately, this occurred on a Friday, and it gave us a chance to get organized before the state descended upon us. But the reason I bring this up is that was 2008. The number of wrong site surgeries has not fundamentally changed at all since that time. And it completely integrates with the comment you made about patient errors. The other comment I want to make is that physician burnout is a very important thing, but so is nursing burnout. There have been over 100,000 nurses who have prematurely retired since the pandemic due to nursing burnout, and we have a critical shortage of nurses in this country. And we can't produce nurses because the education of nurses has been hindered by the fact that nurses who commit themselves to being professors of nursing make so much less money than nurses who work clinically that the schools of nursing cannot find faculty.
Yes. We also agree. Part of the program that we work through is focusing on clinicians as a whole. So everyone that involves patient care. So we know we do support and focus a lot of our attention with our providers. We also know that we cannot have a successful health system without having all of our staff have available access to have education, to have efficiencies. So part of our program is not just for providers, not just for doctors, but also our nursing staff, all of our staff that meets patients after the check-in process. We hear them the same way, we support them the same way, and we work to create efficiencies for them as well. We know that all of them impact patient care, and all of them have the same impact together to create that culture for the patients altogether. Burnout for our providers, we also know is related because not only are they worried about their patients, but they have a direct responsibility they feel for their staff members that support them. We've seen many a times where we've tried to change direction for providers to offload messages onto their support staff. And a lot of responses, I can't do that. What they're doing in the room itself is more important to me real time than answering the messages. I can't have them do that. So that's something that we want to make sure that we're addressing at the same time to allow everyone the opportunity for efficiencies and workload. We don't have all the answers, but that is where we are right now to at least help support and create a culture for everyone to have that opportunity.
And you correctly identified EHR as a stress factor. The other one is the authorization process. Those two things are really driven dissatisfaction among the clinical providers. One of my good friends who's a top internist here in San Diego, when he implemented this EHR, that particular EHR required that he clean his inbox before he could do an order on one of his patients. And he would go home and spend 3 hours at home after working a 10, 12-hour day. And he became suicidal and very depressed. And it has actual real negative consequences for a lot of providers.
Absolutely. And that also deals with the authorizations, making sure that we have the information that goes into Epic, into the patient's chart, is all the information that's needed for authorizations at the same time. So if we have the availability to have accurate information the first time that it goes into the system without having the noise and clutter of additional information that is necessary for some areas, but where the patients need the access, providers need the access, we want to make sure that data is clean and as efficient as possible.
Very good point.
And can I add?
Oh, sorry.
I want to add to that because authorization is a huge point. And a number of the workshops that Rick mentioned have been focused on the authorization process. And this is one of those things, I talked about the 7 levels of change, challenging. When do we place when do we start the authorization process? Do we schedule before or after we have the authorization? We've been working with teams to redesign what gets done when and by who to be entirely patient focused. And I think that has, when we did this survey with our physicians and nurses and team members about, what frustrates you most in healthcare and contributes to burnout, one of the things we heard, the number one thing is seeing a patient not get what they need when I know what they need. And authorizations is one of the biggest drivers of that frustration.
Hi, Todd. Question for you. Is there a focus in terms of beyond hospitalizations, looking at more of a distributed system to keep people out of the physical facilities?
I was going to let you, because telehealth and all that.
You want to?
Sure. Hi. Yes, that is a large focus. Dr. Longhurst mentioned earlier about having at-home monitoring for patients, the availability for them to have that ownership of being able to be at home, but still have communication, still have support from their providers. So it's that extended support system that we are focusing on. We've mentioned MyChart earlier for our patients and for our students to have that availability and education. A lot of areas that we're moving to is within MyChart, providers can send real-time education to patients based off of vitals that they're entering at home. We've talked about blood pressure earlier going in. If patients have a high blood pressure rating, and if staff are monitoring those at the time, these are future areas that we're working on, we can send education that says, post particular surgery that you had, this may be an expected outcome. It's okay to stay home. We can also then develop alerts for our staff members to call the patients to reassure them that if it is something that is expected, or to come into the right area of care, may not be the emergency room. We don't want all of our patients in the emergency room. If we can find another level of care that's best for them in the clinic. And then we can also reduce our readmission rates from there. But at-home care is where we want to be. That's where patients are comfortable. That's where their support system is. That is where they can provide their other level of care, and we can also support them there.
I'll add to that we need to think about this as part of a network, right? There are patients, but they also might be patients at a FQHC or getting care at a nursing facility, or we're not the only ones that can provide care, and so we've actively been working to build collaborations within our network of care for patients. The other thing is thinking about certain populations that can really benefit from this. So patients that have recently been hospitalized and are at high risk for readmission. We now have a program called VTalk, Virtual Transitions of Care, where they're arranged to have televisit, very timely, very much looking for their specific risk factors and if they need to come back or what we can do to mediate from that very preventatively or as early as possible. And the other is, thinking about these options from a health equity lens. Not everyone has access to transportation. We've found, during COVID, who wasn't getting vaccinated, right? And we found a lot of them lived in neighborhoods that had low scores on the Healthy Place Index. And so UC San Diego built the mobile vaccine units, and we went out to those communities and eliminated some of those barriers that people have from transportation or other access issues. So very much great point, and a huge space for us to continue to innovate in. Thank you.
Thank you, Ashley. I think you and the team have given us a lot to think about this morning, along with the JCHI team in the morning as well as we go into the lunch. It's a lot of things to discuss as well. So thanks, Ashley, Sarah, Rick, and Dr. Rob, and also the JCHI team, which is still here. So let's use our time frame during lunch to get to meet people and discuss, opportunities here as well. I want to call out a few people who are here, so that way, if you want to tap into them. Julio and his home lab team have just arrived. Julio is a Rady alumnus, but he runs an incubator accelerator here called Home Labs. He'll be presenting about it tomorrow. In fact, there's a new program that they're announcing to encourage startup formation. If you're there tomorrow, you can get to know more about it, but if you're not there, maybe you can talk to Julio during lunch. And then we have a number of other people who are great supporters of the campus. I want to recognize Martha Dennis, who's here in the first row, who's already been asking some questions. In fact, I think she has been a major supporter of the campus ever since the very early days, 1980s or so, and part of this whole ecosystem, San Diego ecosystem, even before, right? And then, of course, John Madison, who's in the back, and he's going to be a panelist this afternoon, ex-chief medical officer of Kaiser, and very kindly mentoring a lot of our teams here at UCSD. So, and then there's a number of people, senior people here. Walter over there in the back has been a very active participant in our programs. And then we have tech licensing officers like Abu at Scripps Research Institute. If you would please raise your hand. So people who might be able to give you access to some technology. Of course, Chris Loriman, who's been here, UCSD's tech licensing officer. And all of us are here. Preetham Suresh, faculty in anesthesiology, part of our faculty core team. Stephanie Allen, again, I mentioned in the morning. And then there's faculty, PhD students. So it's great that we have a very good turnout today. Thank you so much for being here. Enjoy your lunch. After lunch, we're going to have Dr. Eric Topal kick off the afternoon with his talk. And then we have other sessions planned the same way like morning to go deeper dive into these topics. Thank you for being here.
The book's still not safe.